practical, but we need to sort of
Okay, we're going to resume.
take data-driven approaches. So we have a data warehouse vendor that we've contracted
Please
with now.
take your seats.
I think it's going to be true when we run these extenders. So we're starting to do all that to inform, and I'll talk about all this. So, yep.
Okay, go debunk.
Yeah. So, you don't mind if can I refer to you as a skeptic?
No,
No? Okay.
an empiricist.
Seriously, there we go. Okay. Okay, and then you guys will control the video when I cue it up. Okay. So when I get to that slide, I'll sort of make a mention and point to you. Okay.
Okay, thank you very much. Dr. Dennis Scanlon is our next speaker.
Great. So thank you all. Happy to be here. And, as was pointed out, I have to run not because I'm afraid of what I have to say or because I don't want to stick around and listen to the rest of the afternoon, but I have a son who has a event tonight, important family event that I need to get back for. So I have a 4-hour drive and need to get back. So I'm sorry I won't be able to join you for the afternoon. So I found the first two presentations quite interesting. I think sort of Soren I might describe as, he describes himself as an empiricist. I think there's some skepticism that comes from the empirical work that he presented. I think, our second speaker, Dr. Roizen, clearly enthusiastic, might even argue an evangelist for wellness programs. And so I'm going to sort of probably be somewhere in between. And I titled my talk, Moving Beyond Wellness Doesn't Work. And I'll have to say, I believe wellness doesn't work in its current configuration, but we need to move beyond that. And so I'm going to give an illustrated story, which is largely based on a pretty major disaster at my own university that many of you who are in the wellness industry probably heard of, because Penn State was in the news for about a year, very intensely for about 6 months as a result of this wellness program. So it's kind of fun to beat up on your university when you have tenure. You're allowed to do that. I guess if you don't have tenure, you can try to do that as well. So I haven't been fired yet. So the chapters in this story, and this is kind of the theme that I'm going to go, is a little bit of a story. There's the ACA incentives, the Affordable Care Act incentives, the institutional plan, the grassroots response, the media feeding frenzy, assessing the merits based on evidence, the retrenchment, the post-mortem, which includes blaming Obamacare, of course, and then rethinking strategy, evidence, and implementation. So who wouldn't want to read the book with these chapters, right? So I'll sort of consolidate here. A success story that isn't shapes the healthcare debate. This from the Washington Post, January 17th, 2010. And so a perhaps little-known secret about the Affordable Care Act and the incentives that it went into effect, I believe, either in 2012 or 2014, allowing, under the Affordable Care Act, employers to place more of a percentage of the premium in the form of penalties or assessments tied to so-called wellness indicators or other parameters, was really written into the Affordable Care Act. And as it turns out, as this Washington Post article describes, it's a seductively simple solution to rising healthcare costs. Require workers to pay higher premiums if they flunk tests for measures such as weight, blood pressure, and cholesterol. Then bingo, you not only get a fitter workforce, you slash medical expenses, and we live in a utopian world. Cutting down to the bottom, politicians of both parties embraced the idea and expanded upon it in the Senate reform bill, inspired largely by the claims of Stephen Bird, Safeway's chief executive, Safeway being a grocery store chain. Bird says he has set an example for employers nationwide by rewarding employees for healthy behavior. And so went on basically to Congress and others to say Safeway saved a lot of money through their wellness program. Well, as it turned out, it later came out that the evidence was not there. When people looked at the timing and the interventions and what Safeway did, there was no association between what they did in the name of wellness and what the outcomes were. There were other things that were driving the outcomes that Bird was promoting, things like benefit design changes, cost shifting, cost sharing, changing provider networks, and so forth. And so the story was being told and got written into the ACA, and now employers are allowed to sort of focus their benefit design with some of these incentives and penalties, but based on frankly evidence that probably wasn't quite accurate when the law was made. Our employer was one of those who took this up. Under the advisement, we're a self-insured employer of our third-party administrator. And so Penn State came up in 2013 with a wellness plan called Take Care of Your Health. And I want to read the first part of this. This was a press release in the summer, of course, when faculty are out swimming and nobody's working, right? As part of a strategic plan to better control healthcare costs for the university and its faculty and staff, Penn State officials from the Office of Human Resources have announced a wellness-focused initiative that will begin in July. In preparation for open enrollment in the fall, the plan is called Take Care of Your Health, and it's designed to help employees and their spouse of same-sex domestic partner learn about possible health risks and take proactive steps to enhance their well-being. To avoid paying a $100 per month surcharge, aka penalty, beginning in January, benefits enrolled employees and their spouse will need to complete the simple steps of Take Care of Your Health initiative. I want to point out a couple things here. How did they sort of pitch this? They pitched this as part of a strategic plan to better control healthcare cost, not to help you be well, to help improve your health, but to rein in healthcare cost. And that was a strategic mistake, and I'll talk about that in a moment. The components of this wellness plan, and I'll talk also about when you've seen one wellness plan, you've seen one wellness plan, included a health risk appraisal, and that's fairly standard, although you'll learn that ours was not so standard for a variety of reasons. It included a biometric screening, also fairly standard, a blood draw, looking at LDL, glucose, and so forth and so on, and then a commitment to an annual physical exam. Interestingly, which the recent scientific evidence has questioned whether an annual exam is really necessary for everyone, so wellness plans requiring that. So it was fairly standard in terms of what others were doing, save for this $100 per month penalty or $1,200 per month per year. What was interesting and actually somewhat infuriated me, two things infuriated me initially. One is the notion that this was going to save money and be the panacea to inflation and cost control issues. But the second thing being how aggressively they marketed this. So 2 weeks later, Take Care of Your Health sees record participation following announcement. Really aggressive in terms of you should do this, this is the right thing, again, emphasizing kind of this is going to save money for the university. So I mentioned the HRA, and what was inherently at the end of the cause of the debacle that I'll show you is really started with a question about privacy. So let me cue up this YouTube video real quick. This is from a faculty senate meeting shortly after the
Truly liberal arts. I'll actually start by just commenting that I actually have 9 different questions that have been submitted to me by faculty colleagues just in the College of Liberal Arts, and that's been since the questions to the Senate, the answers to the questions Senate questions have been posted. So I think that's just indicative of how extensive and varied these concerns are. So I'll just start with one and then. The first question is, are you aware that female employees are required to disclose if they are planning to become pregnant in the next year? Is it appropriate that women who refuse to disclose their reproductive plans are fined $100 a month?
That was an HRA question. Health risk appraisal. The response coming up is from a Highmark executive who's our third-party administrator from Highmark. Listen how he responds.
First of all, good afternoon, everyone. And again, my name is Mike Fiaschetti. I'm the president of Highmark's commercial health business, and I want to assure you that your concerns and your privacy are the utmost concern to Highmark. We take it very seriously. We've invested heavily in the privacy. As Kelly said, we serve 5 million members in health insurance. And frankly, we have 32,000 employees here in the state of Pennsylvania, all of whom for the last 10 years have done a health risk assessment. So we take the health and wellness piece very seriously as well. I think that question is in the context of a broader health risk assessment. A health risk assessment that is simply a part of a broader health and wellness program. And that part of the program is really important in terms of understanding potential health risks, health issues of an employee. That information, by the way, is completely and utterly private. We have never, and I will repeat, never given that information over the 15 years that we've done health risk assessments to an employer or anyone else for that matter. That is to assess any issues, any health issues that you may have at health risk assessment, and then develop a plan. I know myself, I started 10 years ago. The first couple of years that I did the assessments, I was skeptical. I thought, I don't believe this. I'm not in tune to it. After about the 3rd year, I finally realized that I had issues. I had personal health issues. And I did consult with my physician, and I got on a path toward dealing with those issues. So I think it's in the broader context of this health and wellness program. There are a lot of questions on the health risk assessment, and it tries to establish two things. What are potential risks that an individual has so that there can be a program and a plan of action to help that person improve their health and wellness and their health outcome? And two is, what is their willingness to change? Again, that is one piece of this broader program that we have in terms of working with physicians, hospitals, in terms of the benefit structures that Susan talked about, and then this is a part of the program as well. But I will tell you that that information is absolutely private. I will stake my reputation on that we have never leaked that information, and we have all the security in place that that doesn't occur. We take that very, very seriously. We understand that issue.
So listen to this next question.
Frontier?
Kim Blockett from Brandywine campus. I have a comment and a question. First of all, as an English professor, I think I'm having difficulty with your definition of private. For me, discussing my reproductive plans with an unknown entity at an insurance company does not constitute private. Certainly, I understand the health benefits and necessity of having that conversation as part of a larger context with my physician. That makes sense to me, not with an insurance company.
Okay, so you see sort of where this is going. This was a health risk appraisal question. You know, presumably the benefit of asking that is maybe to get people into prenatal care, understand, you know, for someone who might be intending to become pregnant. But you sort of see this dilemma between what people feel is an invasion of privacy. Why are you asking me this, and what's happening to the data, versus the administrator's response of, you know, well, we'll keep that all secure, you know, and then the question of sort of what does privacy mean in terms of, you know, who do I want to sort of discuss with or receive help from in terms of something like prenatal care or thinking about pregnancy plans, just as one example. So you can imagine how this story has gone. From the Harvard Business Review, the danger of wellness programs: don't become the next Penn State. So we found ourselves in the news as a result of this. I interjected at this point with a colleague of mine, Dennis Shea, and we tried to we wrote a white paper. We wrote a white paper which is available on the web. We wrote this on the evidence of wellness programs, drawing from Soren's literature as well as others, in comparing that to what Penn State was proposing. But we also focused on what drives healthcare costs, because remember, the way in which this was being pitched was as a solution to an increasing healthcare cost trend. And so we tried to educate the population on what drives healthcare costs and how much of those costs are driven by behavioral changes that might be, in the short term at least, affected by something like the healthcare wellness program that the university was proposing. And I'll talk about what we sort of said in that in a moment. What was very interesting is on this privacy issue, based on that meeting and otherwise, a couple faculty members really made this the central issue. And what happened is not only when you went into this HRA, did you have to answer every question, including some questions that essentially asked about criminal behavior. Have you ever driven drunk? Do you do that frequently? Do you use illicit drugs? As well as the other questions like pregnancy. If you didn't answer one question, if you wanted to skip out, you would still be subject to the $100 per month fine, because you didn't complete the 3 steps of the HRA or of the wellness program. So that was a very contentious issue. Some faculty took that on, and this was picked up by the New York Times, Natasha Singer, that focuses on data and privacy issues. It was a Sunday article, and as she said, on campus, a faculty uprising over personal data. Improving health while holding down healthcare costs is the kind of having your cake and eating it combination that most people can get behind. In fact, both ideas are embedded in the Obama administration's Affordable Care Act. But an uprising among faculty members at Penn State over a new employee wellness plan is challenging at least some of the methods designed to achieve those aims and really gets into privacy. The other thing that people found is when they completed a wellness survey, the HRA, they went in and they noticed that claims data from Highmark was actually being populated in terms of some of that. So immunization records and other things were being transferred from Highmark to WebMD Services, which was the Highmark HRA vendor. And so people went in and said, well, how did you know that I got a flu shot in such and such a date? I didn't answer that question. So people started to really wonder where their information was going. And once this article hit the streets and in the other articles, you can imagine that there was intense pressure on the university for this program. thinking about legal issues, the American Philosophical Association wrote a memo to our Senior Vice President for Finance and Behavior saying, "Dear Mr. Gray and Mrs. Basso, according to an article in the September 10th Center Daily Times and the 15th of September New York Times, a health risk assessment questionnaire that is part of Penn State's new employee wellness program asks women employees whether they plan to get pregnant in the next year. If the employee refuses to disclose this, she is penalized $100 for every month she fails to yield up the information. By requiring women employees to disclose information about their sex lives, Penn State violates their privacy rights and likely violates their rights under federal law, Title VII in the Pregnancy Discrimination Act, Title IX, Privacy Law and Equal Protection. Highmark, Penn State's healthcare provider, targets women employees by imposing on them a special burden of disclosure about their sexual intent. Are male employees required to disclose their intended sexual activity over the year? To avoid paying a fine, is a woman employee forced to lie? And if she has no plans but becomes pregnant accidentally, does that decrease her insurance or increase her insurance premiums?" So some legal questions, clearly, and many of you in the room can kind of understand those a little bit better than I. Not surprisingly, after all this intense scrutiny, Penn State suspends fees for employees who don't take the healthcare survey. Basically, they said, "We screwed up, we listened to you, this wasn't a smart plan, we're going to sort of do away with it," about 2-3 months after it was put into place. And of course, that was chronicled in a number of articles. Penn State eliminates fines for employees who skip wellness questions. But this had rippling effects. This is Representative Slaughter from New York, again published in the New York Times. "A federal lawmaker is asking the Equal Employment Opportunity Commission to investigate employer wellness programs that seek intimate health information from employees and to issue guidelines preventing employers from using such programs to discriminate against workers." And I think we have a speaker from the EEOC who will be talking about some of this a little bit later today and some of these legal issues. So this was our experience. As I wrote that white paper, we basically did two things. One is, because costs were being sort of given as the reason for the wellness program, we sort of identified what the evidence is for what drives healthcare cost in the U.S. health system. And you see things like technology, malpractice, demographics in income, lifestyle and health behaviors, some of which might be influenced certainly by wellness programs, provider practice patterns, insurance benefits, administrative cost, waste, fraud, and abuse, and healthcare pricing, like pharmaceutical pricing, which many people say the U.S. has very high prices relative to other countries around the world. Lots of things drive healthcare cost. Wellness programs might affect some of these things, but certainly not all of them, and not necessarily the ones, certainly over a short period of time, that are really responsible for driving up cost. So there was a little disingenuousness in terms of the notion that these wellness programs are really going to result in cost over the short term. In fact, in some cases, wellness programs actually increase cost because of the cost of screening, because of the cost of finding people who need treatment, and short-term increases in treatment cost. But when it comes to the evidence on wellness programs per se, there's some important limitations that I think are important to understand here, because there's been a lot published. And my reading of the literature is the evidence is mixed. If you look at the bottom line conclusions of articles, you will see some articles that say there is savings, there isn't an ROI. Other articles that say there are not. But you shouldn't believe any of those articles unless the methodology is actually very good. And the problem with this wellness literature is there's vast variation in the methodology used to study this topic. So what do I mean by that? So there are conflicting results, and I'll give an example. Highmark, which was our vendor, which really sold our university these on the wellness concept, referred to two studies that one of its employees published on Highmark's own institution of a wellness program. If you actually get into the detail of the studies, what you find out is one study looked at employees at their Pittsburgh office and looked at sort of the impact of some wellness programs where they installed a state-of-the-art, brand new fitness center within the workplace, within the building where people worked. In addition, if you look at another study, what you found is that, and of course, they didn't control for that. From an external generalizability validity perspective, they didn't say to Penn State, wellness works, and oh, by the way, only if you sort of install a fitness center kind of that everybody can access easily on your campus or easily next to their office buildings. But they emphasized sort of the impact that the results had for Highmark. The second thing is when you look at one of the other studies, they did look at cost, but they failed to look at the full distribution of cost. So we know that claims include Total charges, nobody pays total charges from an insurance perspective, so you have allowed amounts, but those allowed amounts are typically broken down into out-of-pocket responsibility from a member, either deductibles or co-insurance copay, and then there's the amount that the plan pays, in this case the self-insurer. Well, what happened was at the same time that Highmark was studying this, they had increased cost sharing on the part of deductibles and co-insurance to employees. More was being paid out of pocket for every utilization of healthcare. What they only included were the plan costs. So they didn't include the fact that the overall cost, the out-of-pocket cost, were not included in their analysis. So lots of potential flaws when you look at sort of how these studies are done. So what are some of those challenges? Definition and measurement of wellness interventions. What our colleague from the Cleveland Clinic described as a wellness plan is way more intense than certainly what our university and many employers are putting into place. And in fact, some might argue is closer to what traditionally might be called intensive chronic disease management or disease management. You know, the question is, where is the line? What is wellness? What is case management? What is disease management? What is, frankly, more holistic care? Oftentimes, wellness gets coded in a singular binary dependent variable. That dependent variable across the literature represents very low-intensity studies or interventions to extremely high-intensity interventions. If we took and coded Penn State's initiative and Cleveland Clinic's initiative and each coded as having a wellness program, we'd be comparing apples to oranges, not apples to apples. Measurement of wellness participation and intensity of participation. We saw some statistics from Soren about 20 to 40% of people participating. Not only is it an issue of who participates and how much participation there is, that oftentimes is not controlled for in the study. People ignore that as an important variable. But this self-selected participation, you know, it's not just who participates, it's not just how many people participate, but who participates, right? Single case studies with non-controls or historical controls, which is not the ideal way of doing studies. Simultaneous changing of other aspects of insurance benefits, like out-of-pocket costs that I mentioned. The way costs are measured more generally. The time horizon that's examined, is this over 1 year, 2 years, 3 years, 5 years? And then positive publication bias. So when you look at this at the end of the day, there's lots of literature out there, and you can find an article that will say wellness works or wellness doesn't work. But the question is, are those articles done in a scientifically valid way? So if we think conceptually about wellness and how it's supposed to work, there have been a couple authors, Horowitz, Kelly, and DiNardo, who basically identified 3 assumptions underlying wellness programs. First, that you can accurately identify employees with specific health risks and give them strong incentives to encourage participation. That participation in wellness programs will lead to meaningful behavior change and improved health. So even if you can do the first one, you might accomplish the second one, but only for a subset of the population of people who are motivated or become motivated. And then third, if they engage in these behavior changes, that you're actually going to change the health profile in a way that will be cost reducing and health promoting over time. And again, there's a probability distribution over the degree to which that would occur. There's also questions about the value of screening all employees. In our population, I always argued, is we would have been screening many people who had a relationship with a doctor, who likely had the equivalent of a biometric screening within the past year, and we would have been incurring costs that were not necessary to incur because of this one-size-fits-all program that said everybody must do it. We also have the issue of potentially of false positives and associated workups, and then health events and costs related to positive screening materialize with a probability over some future time horizon, and not everything is preventable. So as these authors argue, program savings may not, in fact, derive from health improvements. Instead, they may come from making workers with health risks pay more for their health care than workers without health risks do. So what are some of the key points from this Penn State debacle? I think communication is very important, being genuine. And I think our university wasn't genuine because the emphasis here was not on wellness and caring about employee health, but cost control. And that backfired. It was pretty easy to see through. I think we need to be conscious of the evidence base, and the evidence base is going to depend on the intensity of the, quote, wellness program that you put into place. If you're in a very intense chronic disease management program around cardiac care, around diabetes, around asthma, whatever the case may be, you have a certain level of evidence that's going to sort of back that plan versus a general wellness program, which is typically what we see insurers and third-party administrators promoting in a general population looking at risks. There are privacy issues. We just talked about those in that video. There's the use of carrots versus sticks. Arguably, had Penn State not chose to go the fine route, but maybe a reward route, even the privacy issues may have been less salient to people than the $1,200 per year potential fine. There's the issue of integrating this with behavioral design so that from a motivation and behavioral perspective, the incentives of the wellness program are actually supported by the insurance benefits more generally, deductibles, co-pays, waiving costs for preventive care, which of course the ACA now has done, and other things along that line. How to influence behavior change? Let's face it, a simple HRA filling out a survey and saying, do you wear your seatbelt routinely? No, I don't wear my seatbelt routinely. And then a thing popping up and say, do you know that it's a good idea to wear your seatbelt? Is that likely going to change my behavior? Probably not, because I haven't been wearing a seatbelt for years. Some other intervention or counsel is probably necessary in order to try to get me to change that. And then, of course, if we're really about addressing cost, there are alternative options, such as high deductible health plans, addressing price variation, whatever the case may be. So I like to view this as, I'm a health guy. I've studied health. I've been trained in public health. I do health-related research. Of course, wellness is a good thing. We should strive for it. We should all sort of try to be as well as we possibly can. But when we talk about wellness programs, there's a lot of challenges. So how do we move beyond this simple wellness doesn't work? I think the literature has largely studied third-party programs run by vendors with, frankly, questionable trust and credibility, and there are a ton of vendors out there. I'm sort of working with our benefits office now, and there is all kinds of things that people will sell you, and the evidence base for it, quite frankly, is marketing material at best. I think the future of wellness can and likely will be much different in an ACO, accountable care organization type framework, and with new payment models, because finally, we're starting to get to, and these aren't perfect, away from fee-for-service based reimbursement back to population-based reimbursement, where there actually are incentives in investing up front for keeping people out of acute care situations, for preventing the manifestation of chronic disease, for preventing exacerbations and unnecessary hospitalizations, et cetera, et cetera. And to the extent that doing that will be rewarded in shared savings types arrangements or other types of payment models, then all of a sudden, the provider, the delivery system, the supply side will own this rather than vendors, although they'll want to work with vendors cooperatively. And again, perhaps that's what the Cleveland Clinic is doing, saying, we want to manage this ourselves. And I have faith in these types of programs that are well developed and integrated closely with a point of care, so that the woman who might need some counsel on reproductive planning is actually getting that from a trusted relationship that she already has, that she herself has chosen, and with a care team that she can feel confident in. What's the prologue here? I've been involved as a result of this. There was a task force. We were charged with writing a report to sort of do the postmortem on what went wrong and, more importantly, what we can do, going forward as a university. And then I'm part of an ongoing advisory committee about what some of the alternatives are that we should be looking at. Let me just end briefly here. I have about 5 minutes.
You have about 10, but that wasn't really time for questions.
Okay, so let me try to sort of end here. These were our cost trends since 2005 to 2014. At the time this wellness program went into place, we experienced 13% year-over-year healthcare inflation. I think that's what prompted the university to look for any solution. And of course, this was coming off the recession, where state budgets and other things were severely sort of hampered. And so the university was desperate. We spend about $250 million a year on health benefits, going up at a trend of 13%. The notion is, what in the world are we going to do? So what they do? They asked a third-party administrator who said, "Oh, put in place this wellness program. You can say you do, can tell your president you're doing something, and this will reduce your trend." Well, it's not going to reduce a 13% trend that much. As it turned out, the trend went down nationally afterwards. And of course, the goal is really to buck the trend. This is called bending the cost curve, as many of you have heard on the right. That's ultimately what we want to do, not a one-time decrease, which you can get by cost shifting to employees in the form of raising deductibles or co-insurance or things of that nature. So that's really the goal, is we want to sort of, from a cost perspective, reduce the slope and reduce that long-term rather than just kind of a one-time. So the cost care challenge, I believe, is really, we have to look at achieving higher quality healthcare for the same amount that we spend, which is working with people that can provide better quality for the same amount of money, or achieve the same quality of care for lower healthcare spend, and maybe, again, finding people that will charge you less to provide the same level of quality, or some combination of both, which is possible. That ultimately is, I think, what one needs to be thinking about, both when we're trying to sort of reduce healthcare expenditures and better manage the health of our population. So we're looking at now a variety of different options, both on what I would call the demand side and on the supply side. So the demand side might be things like giving consumers more cost sharing and more choice, and more information in terms of high deductible health plans, consumer transparency tools, and even more comprehensive disease management programs that I would argue are different than wellness programs because they're taking people already with illness and working on helping to manage those illness rather than necessarily prevent or the onset of illness or such. Um, None of these are foolproof. There are pluses and minuses associated with any of these. On the supply side, we could look at things like price variation, of which there's significant amount, and do things like reference or bundled pricing, better vendor negotiations, and I'll just give you an example. As a result of this whole initiative, Penn State was paying stop-loss insurance. We're self-insured to a cap. We were hiring Highmark basically to cover any losses above that cap. We were told by a consultant that we were paying too much. We asked Highmark for a reduction. They said, well, no, you're paying what you should pay. We went and shopped that around. We found out that we could save $500,000 annually by getting a better market premium just by shopping vendors. And lo and behold, we went back to Highmark and they said, oh, okay, we'll reduce our price by $500,000, right? These are the opportunities to save money. You kind of like shopping your auto insurance from time to time. Looking at centers of excellence for high cost or low volume services, reducing non-value utilization, of which there's much in our system, many things that are done to people that are inappropriate and not necessary. Many patients think that these are necessary. And then we're doing something which is a sole source lab contract. So looking at a number of other options, some of these might be health promoting or wellness promoting, certainly they're cost savings as well. The other thing we're trying to do is we're trying to study this scientifically using data, and we're developing a data warehouse. So let me let me end there and basically say that I think, hopefully this case, this experience from our employer is instructive. Again, from my perspective, wellness is something we should always aim for, we should shoot for, but there's no panacea, there's not a silver bullet, it's more complex. And I think at the end of the day, how you design it and how you measure it and ultimately how you study it is critically important. Thanks.
Just one of the things that caused us to do this, and that I haven't seen Penn State, which is large enough to worry about dealing with it, is how do you deal with the influx of chronic disease? That is the trend in type 2 diabetes, the trend in osteoarthritis, the trend in dementia, the trend in all of these means that the cost shift will either have to be so great or you're going to have a huge burden. So how do you deal with that without trying to get a healthier workforce, without trying to help your workforce get healthier?
Yeah.
In other words, you're saying we're going to help it get healthier by just doing the market, and maybe if the deductible plan gets high enough, what'll happen?
Mm-hmm. Yeah, so I think a lot of times this is a question about sort of do we try to do this in the context of usual care, where usual care is fee-for-service based driven. It's where people choose whatever provider or providers they want, and it's a set of providers that operate under a fee-for-service reimbursement model with not necessarily any enlightened wisdom of how to manage chronic disease or patient populations. That's the healthcare delivery system we've all grown up in. The alternative is to think, let's create a new model, a new system, and let's get people into that. But that's easier said than done, particularly in central Pennsylvania and the places where we have our campuses, where people, where we have existing delivery systems that have historically and continue to operate under a fee-for-service model. So providers who haven't had an incentive to change the way they provide care, patients who don't know any better one way or the other, and therein lies the problem. So I think the way in which you can think about it is, can we partner with exclusive provider arrangements that get it and that want to change care, that want to think about the chronic care model, that want to think about team-based care, that want to think about shared decision-making, that want to think about behavior and motivation change, and are willing to change their model to better manage our patients?
And have you?
We're thinking about it. The problem is there's a scarcity of changing the existing status quo.
What you're talking about is moving to the ACO, or the Accountable Care Organization, if you will, as a provider for all of, and there, in other words, it looks to me, looking at the faculty senate at Penn State, that there will be, when you go to if you offered ACOs as the only model on the website,
Right.
it would be a revolt of the
Right.
faculty.
I mean, that's the challenge in American medicine is we threaten choice, which people value, when in fact we might be choosing providers that overutilize on unnecessary care, that don't do a good job managing
No,
patient
but I'm just
populations.
wondering how you're obviously involved in the discussion, and I think that's a huge issue for America and for equality in America,
Right.
and for income equality. And so I just wondered, how are you dealing with it? Because you're right there on the front line.
Yeah, so dealing with what? I'm not sure I understand.
Dealing with this switch, are you going to make the switch? How are you planning on bringing that switch about for your...
Yeah. Well, it's as I said. I think first we're trying to understand whether there's an adequate supply from a delivery provider system that can actually provide the care that would be better for our patients. If we knew there were models out there, and Geisinger is a main provider in our market, they do some things well. But the question is, to switch to something better, you've got to have something better, and that's not easy to transform sort of American medicine as even a large purchaser when the rest of the system, the usual fee-based reimbursement. But I think the system is changing. But we'd love to have clearly documented and evidence better choices that we could then figure out politically how to sell to our employees with evidence. But we're not there yet in our markets, and I think that's the challenge. We all want to be there, but we're not there yet.
Dennis, I have a question. And that is, you mentioned the data warehouse
Yep.
at the end of your talk. How is that avoiding the privacy concerns that brought down the original configuration?
Yeah, excellent question. Excellent question. And I thought that would be a bigger issue because a data warehouse is all about sort of taking claims and whatever other information you can get, de-identifying it, of course, and trying to sort of study it. But you always worry about, is de-identified truly de-identified, as you drill down to small numbers and small sample sizes. Surprisingly, I think there was some trust building. By writing that white paper as a faculty member, the privacy people who were outraged, my colleague and I and a couple others sort of put ourselves sort of somewhat in between. We became trusted among the faculty who said, all right, you're willing to sort of write this white paper and criticize the university. And then when it came to these advisory committees and so forth, the people who were most critical about privacy were very concerned about who was being represented on these committees. And they lobbied for myself and for some others to kind of have representation on those committees. So I think there's a little bit of trust building, that we were willing to criticize, but now we're willing to try to help. And so I think one of the things we've tried to do is explain how a data warehouse works, how it can be done in a de-identified in private way, and what the potential value of that is. So what is the potential value? If we look at price variation and we look at a concept like reference pricing, reference pricing is simple. For an MRI, if you've got variation of this much, you set a price somewhat here, you cap how much you're going to pay. And what CalPERS in California found, for example, is for hip and knee replacement, they set a reference price of $30,000. They found, lo and behold, all these providers that were charging $42, $45 quickly gravitated to $30 instant savings for the same sort of bundle of goods. There's value to doing that, but in order to put that in place, you need to A, know how much price variation you have in your population. A data warehouse helps you do that. And B, to know whether you have enough supply of providers. If I set a reference price, but I don't have enough people that are providing the service, that's going to backfire as well. So we tried to sort of emphasize the value that one can get, largely for holding the supply side accountable. And that's another story here, is the high costs that we have are in large part driven by lack of competition on the supply side. Monopoly hospitals and health systems, there's been consolidation in the industry, high-cost pharmaceuticals, and we can put money in cost sharing on the backs of employees, and we probably need to provide some incentives on the demand side, but we need to hold the supply side accountable, and that's an incredible fight. To take on the Cleveland Clinic or any other system in Ohio for their prices, if in fact they are high, you got to go in armed and prepared, and companies like Highmark aren't willing to do that. And we basically said, we need to be willing to do that, and we need to be willing to do that armed with our own data. So I think those people concerned about privacy want to know about how this will work and who has access to it, but they also see the potential advantage of it.
A question. You seem to be in a unique situation in which you have an associated School of Medicine and medical center. Why wouldn't you take that and use that to the advantage of the university as an employer, as Cleveland Clinic may have done?
Great question. They're lobbying. Our Hershey Medical Center is lobbying to manage our patient population. But I trust, yeah, I mean, I say this with a grain of salt. There are some good people. We have to go into it that we can't trust them completely. We need to see data and we need to see evidence. And our story is a lot of our population at our main campus is managed by Geisinger. Outstanding reputation, outstanding model. If you ask the Hershey people, Geisinger's prices are through the roof and outrageous, and we're getting ripped off by Geisinger. But yet people love the care. Geisinger has been nationally prominent. They have many things they do with high quality. And getting employees and moving them to Hershey when they like Geisinger is something we've got to be very conscious of how we do that, right? Having them sort of leave their provider. On the flip side, our Hershey Medical Center is telling us we can do this. We can manage your patient population. You know, we can be the Cleveland Clinic for Penn State. And there's some sincerity, but quite frankly, they just got an electronic health record implemented a couple years ago. They're still working on it. When it comes to disease registries and care coordination and the left hand knowing what the right hand is doing and sharing information, they're not quite there yet. They're an academic medical center that's used to the academic medical center model. So it's very difficult for me, and I guess I enjoy sort of being that naysayer at the meeting because people are lobbying on both ends. Oh, Penn State should do this because Geisinger is ripping us off. Well, you know what? Geisinger has some demonstrated good quality, and oh, by the way, where's your care coordination now? We're moving in that direction, but again, there's no panacea here. And there's some geographic issues as well of where our employees are and where our academic medical center covers.
I'd like to try to make this a short question. It may not be. How much leadership is Penn State now enjoying as a result of the incident and the kind of work that you're doing? That's question number one. Question number two, is there a trickle down to the student body, body politic, any changes in curriculum, any required coursework along the wellness theme?
Yeah. The first question again was? How much leadership? Yeah. Right. Yeah, the leadership, I think, is when you look at benefits people, they don't, and when you look at the bad press that we got, I think there's a lot of concern about just not being in the news. So I don't think our leadership is trying to sort of, first of all, we haven't solved the problem. We're still working on it, so there's nothing that we're really leading on other than maybe sort of acknowledging a mistake and trying to move forward. But we haven't done anything to solve this issue yet. So I don't know that we can be viewed as a national model other than sort of how to not make a mistake. So I also think that, even if we were successful, there's probably a little gun shyness of getting in the press because even if you're put out as a leader, somebody will sort of maybe talk about why what you're not doing as well. But I think the more important point to your question is, the real challenge of doing this for a university that has 45,000 covered lives, spends $250 million a year, is our benefit staff, both in terms of numbers and intellectual capacity, to handle these issues and to understand how to use data, to hold the supply side accountable, to communicate effectively with employees, to communicate trade-offs about the value of a data warehouse versus trade-offs on privacy are incredibly difficult and require intellectual capital that we frankly just are understaffed on. And if you look at benefits offices for major employers across the country, benefits is not where people invest in terms of staff. They're investing in research and development and other things. And so to tackle these challenges as an employer is very, very difficult. We have hired somebody who comes in as a senior vice president level that has some experience, and that's helping. But it's a culture change, and so it will take time. The second question about educating students, certainly I'm trying in my classes, and I think others, in our department, we train administrators who go on and work at healthcare organizations, who work for insurance companies, for pharma, consulting, et cetera, et cetera. We build this kind of stuff in our curriculum. We try to bring these experiences from our research and our consulting and experiential background into the classroom, and I think that's critically important because whatever side you're on, these are real issues. Cost are real issues, quality are real issues, managing chronic disease populations are real issues, incentives are real issues, and any student who's going to be worth their weight working for any organization down the road needs to understand these.
So thank you very much, Dr. Scanlon.
Thanks.
Safe travels.
Thank you.
And Dr. Click.
Thank you. As we transition to slides, it's my pleasure today to be talking with all of you about what universities are doing with wellness across the country. And while we know that corporate wellness programs have been in existence for the past 3 decades in some instances, the environment in regards to university work, as we've heard from the Penn State example, and as we see from other institutions is rather new. So they are, as an entity, not doing wellness for as long as corporations. And over the course of the time that I have with you, I'd like to share details about the work that we are doing here at Case Western Reserve University, and then give you a few examples of programmatic elements that are included in other wellness programs in other universities across the country. So back in 2012, when the university was interested in starting a wellness program, we adopted the mindset that we wanted to make this an easy choice for people, that if we could really tackle the culture of health initiative that Dr. Roizen has referenced and others, that would help us advance the work that we were doing. We also wanted to focus on daily environment policies and look at the big four topic areas that Dr. Roizen had referenced that you will find in most common wellness programs across the country. Those big four are, again, tobacco, nutrition and weight management, physical activity, and stress management. And these were some of the conversations that we had in regards to development of our initiative. We have used as a model primarily the Wellness Council of America 7-step approach and the Health Enhancement Research Organization criteria in regards to success. So we had the senior level support. President Snyder was the initiator for this work. There were many faculty and staff that were interested in bringing wellness to the university, having in close proximity the clinic program, university hospitals, and other big corporations in the Cleveland area. We worked on establishing teams, which I'll talk about in a few minutes. We have worked to incorporate data and are moving forward each year with an annual operating plan with a multi-year strategy. And at the end, I will reference some of the work that we're doing as next steps to try to grow that. So the vision that we started off with in our program was to look at our campus environment from the worker perspective to enhance the health and well-being of faculty and staff. We wanted to maximize health and wellness. We want to keep the healthy people healthy, help those that have high risks move to lower risk levels. And we would do that with the knowledge that quality of life would be impacted, productivity would be impacted, and that over time we could view these initiatives and this comprehensive approach as a method of working to control healthcare costs, knowing that that takes time. We have put as primary focus the need to reference data because we wanted to have the approach where data drives program development. We knew that data would impact what we did with our benefit plans as well as with the wellness program. And so we've worked to assemble for the first time in one place benefit claims data, pharmacy data, a health risk appraisal database that we've worked on, biometric screening, and then the other data components that you have listed there, workers' comp, short-term and long-term disability, absenteeism, et cetera. So for us, we came into the development of the wellness program without having all of that data in one place. I'll talk about our insurance carriers in a minute, but the work in this data area allowed us to pull that healthcare claims data together too, and we are still 3 years into this effort working to understand all of those data elements. As we have looked at some of the data, we have seen that, as with other organizations, the number of risk factors tracks in synchrony with healthcare costs. So we've seen, as with many populations, when you have individuals working in your institution who have a higher number of healthcare risks, their average healthcare costs increase. And so this slide features that, along with the division of the medical cost component and the pharmacy cost component. We started this initiative back in the fall of 2012, and we did that in a very small way with just a random raffle opportunity for people who might have interest in completing a health risk appraisal. We chose to use the one from the University of Michigan's Health Management Research Center. We had approximately 500 people do that in the fall of 2012, and reports went back to them, and we used that as a base for some of the data analysis and evaluation that we have continued to work on. We developed a multi-year plan in regards to the programmatic elements that we would put in place for our program. We established a health advisory committee of approximately 25 individuals, capturing senior level administrators, faculty, and staff, representatives from all major schools on our campus, as well as major departments, so that we could have their input in regards to the development of the program. And then last year, we rolled out a Wellness Champions pilot program so that we could really start to leverage the passion and energy of those people who are in different levels of the organization to try to grow this in a sort of peer-to-peer fashion. Our health management action plan has focused on rolling out an incentive program that has two components, which I'll explain in a minute, and is growing as we speak. We are getting ready to embark on an integrated benefits and well-being strategy planning process, and so we will be able to take some of what we've learned in these first 3 years and look at measuring outcomes further. At the university, we currently have 4 different insurance plans. We work with 3 carriers, Medical Mutual of Ohio, Anthem, and for a few more months, HealthSpan. We have the largest participation in the Anthem PPO, Medical Mutual's PPO, then the HealthSpan HMO, and then our Anthem high deductible plan. And we have approximately 85% of faculty and staff who are benefits eligible taking our insurance here at the university. And so, of course, when we were first communicating the fact that this program was starting to our population, we talked about the fact that this makes sense for us in regards to being a self-insured plan and having most of our members within those self-insured options. Our program focuses on 3 different activities that we have over the past 3 years now offered in the fall of the year. So in the fall of 2013, we rolled out these activities, and we communicated heavily in the 6 months prior to the population here at the university to talk about what these activities were, how people could participate in them, and what some of the benefits would be. The health risk assessment I told you comes from the University of Michigan. We've partnered with Quest Diagnostics on our biometric screening. And then we also wanted to incorporate the tobacco component. However, every wellness program, of course, needs to be customized to the culture and environment of the institution. And there really is not a lot of interest back then, and I think probably still now, in regards to an outcomes type of approach that the clinic has. So with tobacco, we purely decided to ask, do you use tobacco or do you not? And we then said, if one uses tobacco and one wants to participate in the incentive component of our program, we would ask people to complete a tobacco cessation program before the monthly incentive would be delivered. So for the past 3 falls, we have had faculty and staff complete these 3 elements. If they choose one of the insurance plan options that we offer at the university, then people get this $25 monthly wellness premium incentive over the course of the year. It's a voluntary program, participatory based, and we have done well in regards to generating participation. We report the incentive, the monthly incentive, in the earnings part of people's paychecks. And then we also have a second component. So once people are in this monthly participation option, people may participate in programs in 4 different categories and receive $100 for one program, $100 for 2. So the total potential benefit that one might be able to achieve if they participate in all elements of this would be $500. The 4 areas that we have focused on in regards to participation are those big 4 areas that I mentioned in the beginning. We've structured guidelines in regards to what participation means in each of these categories. And when people have done those activities, we have forms within our PeopleSoft program, HCM, that allows people to attest to the fact that they've done this, that they are honestly reporting what they have done, and then at the end of the calendar year, those monies are delivered. Programs that we offer are on-site and now, as of this year, online. And this slide gives you just a bit of a flair for what the programs are that we've been offering. We have partnered with university hospitals here in Cleveland to offer the SMART Stress Management and Resilience Training Program. We started with this program in part from a conversation I had a few years ago with Dr. Roizen, where we were talking about the significant impact of stress on people's lives and how important it is to really help people manage stressors. So this was one of the first programs that we offered, and we've had probably 900 people on our campus participate in at least one or two of these programs. This year we've offered a third version. Meditation, mindfulness, various types of nutrition programs, plant-based nutrition, a variety of tobacco cessation programs, physical activity options focus on how can you stay flexible and in condition while working during your day, possibly seated most of the time through workstation workout, healthy backs and bodies. This year we have started our first online competition for teams within the university using a program called Health Trails, where we've got 255 people currently participating in this 12-week program. And then we have other programs that we've offered that we have received favorable responses to. In particular, recently, a financial well-being program that we're working on. We've partnered with a company called Self-Help Works to have online programmatic offerings similar to these categories, as well as diabetes and alcohol management. And in the first 2 months of offering the online program through Self-Help Works, have a number of success stories in regards to people quitting tobacco, losing weight, managing stress, et cetera. We also have worked a lot to try to make sure that we have leveraged the resources for health and well-being that are currently available through our health plans. So to make it easier for people to understand what kind of discounts might be offered to Medical Mutual participants, what kind of health and well-being programs does Anthem offer, how can we offer flu shots on campus and do that in a way so that people have more access. Our outcomes to date have focused primarily on participation. We recently have gotten some reporting from the University of Michigan that looks a bit more in depth at our population in regards to that risk status, and are we doing well at keeping low-risk people low, and how have people migrated over the past couple of years, either from high-risk categories down to medium or low-risk categories, or vice versa. And the reports, are looking well. It's been quite a long-term process in terms of assembling all of this data that I mentioned for the first time. It's taken us quite a long time. So the outcomes I think we will continue to be tracking, and we still have more that we have yet to receive in regards to truly looking at some of the impact, early impact of programs on claims and programs on other kinds of health measures. So today, in regards to participation, in 2015, we had 55% of the potential audience who could participate and receive our monthly premium incentive do those 3 activities that I talked about. Interestingly, we have hovered at this mid 50% participation range. We started off at 56%, 54%, 55%. The sub-bullets that you see track some of the participation that we have in some of those 3 activities as separate elements. So for example, we have many more people completing the health risk assessment, completing the biometric screening, who just haven't done all the other activities and gotten the incentive because they have our insurance. So we're looking at, out of the total population, closer to the mid 60% and up to 69% of unique employees actually doing some of these activities, and many reports in regards to the benefit that they have achieved in regards to knowing more about their health from the health risk appraisal, as well as knowing more about their numbers through the screening. When we look at the wellness program incentive, which are those monies, $100 or $200 that people can get for participating in programs, take a side note to mention that the participation can be in programs that we offer on campus that you saw on that previous slide, but also can be in options and opportunities in the community and elsewhere, as long as they meet our guidelines for participation. We've had 47% of people who get the monthly incentive claim these extra program incentives at the end of 2015. And when we look at the total employee population participating in different on-campus programs, last year we were at about 22%. So our goal is to work on keeping healthy people healthy. Many of you are probably familiar with Dee Eddington's seminal work at the University of Michigan's Health Management Research Center, and he has robust data in regards to the value of this, especially as people age and as time progresses. We started this off knowing that we were capturing a healthier audience. When we compare on this slide our group that has a healthy wellness score level, our population is actually tracking at a higher score level than the comparison benchmark population in the database that the University of Michigan has. And we see that the number of people actually in each of the risk status levels is better than their benchmark component. So we have more to do in regards to understanding this, but we each year have had a higher total wellness score amongst the people participating, and we were encouraged in regards to the fact that the total group participating was healthier. Having said that, we will definitely need to look a bit further, because we do know that we have some people who are choosing to not participate for a variety of reasons, and we might be capturing some of those early adopters who have some healthier characteristics already. We also have looked at cost by age group and risk status, and as you would expect, in this slide, you will see that we find that as people get older, their risk status changes, and we have more people in those high-risk categories. And we also see in this particular slide that as people have higher numbers of risks, their risk status equates to greater expenditure in regards to healthcare dollars. So we work on communicating the components of our program in a variety of ways. The communication piece from a program perspective is extremely critical, and we need to keep these messages in front of people on a regular basis. There has been a significant learning curve in regards to educating our population on what we're doing and what the benefits available are. So we have a wellness website that we use to feature some of these activities. We have a Facebook page. We have a monthly newsletter that goes out to all of our participants in the incentive program, as well as anyone else that would like to get that, which features not only health education information, but information on these programs and services, so that we really can let people know what is available, and so that when the time is right for them, they have a variety of options in these key topical areas that they can participate in. We have worked also on the environment component a bit. We advertise a one-to-one fitness center, which is our on-site fitness center featured in the middle picture. And we've worked a bit in regards to environment to try to let people know that there are healthy options out there. A nutrition subcommittee, for example, worked on a healthy vending proposal when an RFP was going out, so that we could increase the number of healthy vending options available, so that we could have special signage in the green on the right letting people know what the ingredients are of those healthier items. And then we also have started the initiative of spreading the free exercise equipment, take the stairs signs in various buildings, and many interesting stories have evolved in regards to people taking the steps more often, sometimes working in small teams to deliberately go up and down the steps on a regular basis a couple of times a day, and we will continue to work on spreading that in other buildings also. There should be a few in this building, although the stairs are a little bit hard to find here. So what are other universities doing that we have not approached yet? There are a variety of other universities out there that have also branched out into providing similar types of incentives to spouses. Health coaching is a strong feature in many programs. You know, looking at the group that wants to make some lifestyle behavior change, looking at health risk appraisal results, and offering the opportunity to really work on those results and the screening results to make some positive lifestyle changes. There are some that are discussing outcomes-based programming, fitness center reimbursements. Manager and supervisor training is critical. We know that that's something that we need to work on here. We need to have all levels of the organization supporting and realizing the benefits of what we're trying to do in regards to morale and health. We have examples across the country, in particular at the Health Enhancement Research Organization conference. It's not uncommon to hear about productivity impact evaluations that are occurring, and similar types of studies that look at some of the positive outcomes associated with their work. We see some institutions looking strongly at the Gallup well-being categories and really trying to focus on community and career and social dimensions because of the importance of building community and relationships, and that is a contributor to well-being. And then Some institutions have also instituted premium discounts, another form of incenting. So incenting different participation in some of the health risk appraisal and screening components, but also some programmatic components. We, as I mentioned a few minutes ago at the university, are getting ready to embark on an integrated benefits and well-being strategy planning process. We have worked to leverage what we have available within our health plans that focus on health and well-being, but we want to go further in regards to really trying to bridge and form some connections similar to a few of the ideas that Dennis shared, so that we really can start working more with the insurance marketplace, so that we can focus a bit more on disease management. We have brought disease management to all of our plans, but we want to try to increase participation in what's offered. And so in terms of next steps, we will be looking at this strategy as an important planning process and discussion process for moving forward with the next steps of our program. So we have achieved a variety of positive outcomes to date. Our participation has been very good. Most comforting and wonderful have been all of the unsolicited positive feedback statements that have come verbally, via email, and then many of the success stories that I've referenced that we keep track of, that we work to promote, so that people can realize what some of the changes are that people have made as a result of the program being present, as a result of participating in the programs and activities that we offer here. And we will work to continue to let people know, because we see that the success of one, for example, in quitting smoking through the Self-Help Works program begets additional people feeling that they also have the opportunity and the capacity to make those similar kinds of changes. So that gives you a bit of a better understanding of what we've done here at Case Western Reserve, some of what other universities have offered and are doing, and I look forward to questions that you may have. Thank you.
Hi, thank you for your presentation. My question, you said that the employees can earn up to $500 annually. Is that on a taxable basis or a tax-free basis?
It does, excuse me, the money does come to them in their paychecks as earnings, so they do end up getting taxed.
So I have a question. I'm insured by through my spouse, so I haven't taken the tobacco assessment
Attestation.
attestation. Is it really? Do you smoke or not smoke?
Mm-hmm. Do you use tobacco?
Do you use tobacco? Because I had a contact from an alum whose brother was in New Hampshire and had to fill out something, and he had had one cigar during the year, and was afraid that if he lied and said no, I don't use tobacco, that he would get into trouble. So he said yes, and he got into bigger trouble because all kinds of insurance consequences happened and so on. He was not in a university setting. Why is it such a gross measure? I mean, shouldn't we be interested in reducing tobacco use, not just in yes or no? I mean, abstinence?
Well, certainly the goal is in regards to reducing use of tobacco. The interest in the university initially was to assess what people were doing in regards to use, and we used this simple question as a way of getting people into cessation programs. So we have actually had a number of success stories in regards to the attestation form leading to people quitting. We don't actually require participation in the cessation program to lead to quit status, but we believe that if a tobacco user is repeatedly completing the attestation form over time when they are participating, they will quit. So the goal is to encourage less use.
But we don't care whether they're smoking 2 packs a day or 1 cigar a year, in terms of the answer to that question on the form.
Well, right now we have not looked at frequency. Yeah.
Similar question to the one I posed to Professor Scanlon. What kind of leadership role is CWRU achieving? Have you gotten plain dealer recognition? Are you head and shoulders above every other university in Ohio? I happen to live in Virginia now, but I'm originally Ohioan. And also the trickle down to the student level. When I was a law student here, the dean whose name I've forgotten at the moment, challenged me to a game of squash. I was delighted. He was quite a bit better than me. But it was teaching by example. And I'm wondering, you mentioned the champions idea. I recently came across that. Is that a sort of natural leadership, or is there a construct? How do you actually promote that through the university community? I hope that's 3 questions.
Sure.
2.5 anyway.
So in regards to the first question, we've worked hard to make sure that we structure our program using sort of the standard success factors and benchmarks. So while every university program that you look at may have different features, we have the strong core elements of what other universities have. We did just recently in 2015 go through an application process to the Healthy Ohio Healthy Workplace department here in the state of Ohio, and were awarded a bronze award in regards to being a Healthy Ohio worksite. There are a few other colleges and universities, but more health systems and corporations, so we were pleased with that result, and we strive to higher levels in the future. So we hope that we can serve as a good example for others, and that was one good acknowledgement of the ground that we have covered so far in the first few years. We see in regards to students that there are growing efforts in regards to the recognition and of importance for health and well-being on campus. My work has purely focused on employees, in part because that is where the initial attention was and because of where our monies come from for the budget. However, we see many great examples of health and wellness initiatives on campus. The School of Medicine now has a wellness pathway, so there's a small cohort of students who are doing special work over the course of a semester throughout the year, looking at wellness components so that they can enhance their self-care and look at how that can impact their patients. For many years, as a faculty member in the School of Nursing, for about 10, I taught a graduate health promotion course that looked at self-care and well-being for nurses and future nurse practitioners. And then we see on our undergraduate level here on campus that our Student Affairs Office is really looking at how can our health services and counseling departments work together to further address student well-being. And students are asking for that. So I think that this will be an area where we grow. Was there one more question?
Yeah, I'm curious about the nearly 50% of people who are non-participants. Of that group, are you finding a trend that you're getting more participants the longer this program is in existence? And secondly, is it possible that a good portion of those people are actually quite fit and they've been doing their own program for years and they just are oblivious to some new program coming along?
Right. So we do know through surveys that we've done of non-participants that there are a wide variety of reasons why people might choose not to do this. Some of them are similar to what we heard. There were questions initially when we rolled out some of these elements in regards to privacy, and so I would say, trust in regards to the process and questions in regards to data, in part for some people, led to them choosing not to participate. We had some evolution in regards to our language around the tobacco question, and so there were a few people initially that had the impression that if they used tobacco, they couldn't participate, and that initially affected our numbers. When we look at our participation over the past few years, we do see that we have more people participating, but we also know that there are some people making different choices each year. So from year 1 to year 2, we had a couple hundred people who chose not to participate, and in part, those people reported back that they felt it wasn't, they didn't want to they chose not to spend their time that way. The time they felt was valuable, and they weren't getting as much from their participation, and the financial incentive didn't feel worth it to them. I do think that we have, and every program has this happen, you get the early adopters who are doing well at taking care of themselves and opt into these programs, but we also know when we look with some of the charts that I showed that we do have people participating who do have risks, and some of them have very significant risks when you look at those that have 5 or more. And some of the early data that we have that's tracking some of the change is encouraging. I mean, we've found in some data that we have a statistically significant result in terms of lower smoking rates amongst those that were reporting smoking and participating. And we see some statistically significant results in regards to change positively in physical activity level, and those we find encouraging. We also see a bit of interesting data in regards to people reporting less use of sick days, but that needs some more explanation and exploration.
Does anybody have a question for Doctors Roizen or Matkey? Or for Dr. Click? I mean, in other words, open forum for a few
Thinking
minutes.
about the tobacco issue and one cigar a year, or perhaps like my spouse, perhaps 6. Dr. Roizen, the clinic uses lab results. Would the lab results show up negatively for an occasional cigar?
Yeah, the lab results are set at a level, we wanted to make it relatively unchallengeable. So the lab result we have set as the trigger is what a secondhand smoker would receive in tobacco input if they walked through secondhand smoke with some regularity, not if they had a spouse who was smoking. But in other words, we want this to be able to be attributable to the smoker themselves or the tobacco user themselves. Unless he or she smoked the cigars right before their tests, they would be negative.
Oh, good. Okay.
By the way, just, I mean, as some of these questions have implied, there is very good data on a dose response of tobacco. So the question has merit, meaning when you get over that secondhand smoke, you get a much greater health effect. So our whole goals in doing this were to educate people about health effects and what would happen to them and their body relating to the health effects of the activities. Just to go one step further, the test does detect hookah use, and an hour in a hookah parlor, which is one of the things that college students are doing now, is the equivalent of smoking 16 to 24 cigarettes from a tobacco damage standpoint. So the point is that that is a major focus, I believe, of education that should be on campuses, even though you're not involved with students. But it is something that I think, and that the Cleveland Clinic has been actively working with the regents of the state of Ohio, colleges and universities, to try and enact on-campus smoking bans, because it turns out from a smoking standpoint, if you don't start by age 25, you're very unlikely to start smoking. And the second component of that statement is that if you're going past high school, that approximately 50% of the people who smoke, if you will, and have got more than a high school education, pick it up in their freshman year of college. So the effort has been to ban all smoking on campuses and to try and educate about the effects of hookah.
As a side note, I was just going to add, as a side note in regards to what we're doing at the university, the past 2.5 years have been focused on a draft tobacco-free campus policy that we have support for now through our faculty senate and our staff advisory council. Our students are having a referendum as we speak in regards to this, but we have strong support for moving forward with becoming tobacco-free.
Okay, last question.
I have a question that piggybacks the dean's question, Ms. Click. Have you considered opening up your outcomes programs, not the screening, to non-participants of your health plans?
Great, that's helpful. A good question in regards to further explaining what we've done. We initially started offering programs to the people who were in our benefits eligible pool. We now offer these programs to anybody on campus that fits into the benefits eligible category, and they can have our insurance or not. The insurance piece is not a requirement. So we see that participation is across all different faculty and staff levels. The incentive pieces are tied to having our insurance, but the participation in the programs is not.
Okay, well, thank you very much. I'd like to thank our speakers for an excellent set of presentations this morning. Lunch is served in 2 rooms that-a-way, and we'll reconvene at 1 o'clock for the afternoon session. So thank you again, speakers.